Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for September 16th, 2025. This week, we're zooming in on a set of studies that challenge conventional thinking and reframe how we interpret clinical trajectories, trial data, and even basic physiology. We'll look at a provocative ECMO physiology study, a closer look at symptom journeys in the ISCHEMIA trial, and a landmark target trial emulation in type 1 diabetes. In addition, we have a state-of-the-art review on secondary mitral regurgitation and a call to redefine the early stages of cardiogenic shock, and then a few reprinted articles from the other JACC journals. And we begin with an editor's page that reflects our broader mission, raising the bar in cardiovascular science. So in June 2025, the White House Office of Science and Technology and Policy issued guidance on what it termed gold standard science, a framework meant to improve the transparency, integrity, and impact of federally funded research. It outlined a set of 6 guiding principles: reproducibility, transparency, critical appraisal, openness to null results, interdisciplinary collaboration, and unbiased peer review. We took a close look at this, and we thought we should write about it. At JACC, honestly, we strongly support these principles. But let me be clear, we do so not as a political statement, but as an affirmation of values that are deeply rooted in the culture of high-quality science. This is not an endorsement of any particular administration or political agenda. Rather, it's a moment to say these principles align with what we already stand for. In fact, our journal has long been committed to these ideals. Our editorial process emphasizes methodologic rigor, scientific humility, full transparency, and careful peer review. We value well-done science, regardless of whether the results are positive, negative, or null. But while we support the goals of this gold standard science framework, we also emphasize a key point. Editorial independence is a foundational principle. It's essential to the integrity of science. Journals must remain free to evaluate submissions and guide the scientific conversation without pressure from political, institutional, or commercial interests. Upholding this independence is as important as any other principle. We believe that journals should be transparent about their editorial standards, accountable to their communities, and open to evolving best practices. And we must also protect the autonomy that allows journals to make principled, evidence-based decisions in the service of science and public health. So as we, quote, raise the bar, end of quote, it's not in response to public directive or policy mandate. It's because that's where we're already headed. Our job is to be a trusted steward of cardiovascular science. And that means promoting work that's credible, reproducible, clinically meaningful, and worthy of the trust you've placed in us. Gold standard science, when understood in that light, isn't a new direction for JACC. It's simply the next step on the path we've already chosen. I hope you enjoy this editorial piece because it really was a reflection on something that was being promoted from a political perspective, but that rather than reflexively react to it, we thought deeply about it and said, there's a lot of this that's aligned to what we're already doing. So now let's get to the research. ECMO flow and pulmonary capillary wedge pressure in cardiogenic shock. We begin with a high-fidelity look at hemodynamics during VA ECMO from Sora and colleagues in the PAPO flow study. Conducted in hospital in Paris, the study enrolled 80 patients with refractory cardiogenic shock stabilized on femoral VA ECMO. Now you may say 80 patients. Well, it was because of the density of information that was collected about these patients and the insight that it provided. In a systematic, stepwise protocol, ECMO flow was increased from 2 to 4 liters per minute. The expectation, higher flow would increase LV afterload and raise pulmonary capillary wedge pressure. But that's not what they found. Pulmonary capillary wedge pressure decreased in 36%, remained stable in 58%, and increased in just 6%. These hemodynamic shifts were most favorable in patients with better baseline RV and LV function and lower central venous pressure. In their editorial, Bloomer and colleagues write, "Have we allowed the mantra of early proactive unloading to outpace the data?" They highlight a key tension in ECMO management. We may be acting on reflex rather than physiology. The findings suggest a more individualized approach to LV unloading is warranted one based on patient-specific hemodynamics, not algorithms. This is one of the most detailed human physiologic studies on ECMO flow in decades, and it prompts us to ask, what exactly should we be doing for whom? And it makes an important contribution, even with only 80 patients. The next paper is about angina trajectories in the ISCHEMIA trial. So these investigators did a novel trajectory-based analysis of angina outcomes from the ISCHEMIA trial, and this study was led by Ikamura et al. Traditional analyses tell us whether symptoms improve on average. But here, the team used latent class modeling to identify 6 distinct patterns of angina evolution over time. Look, this is what we do in practice. We don't just ask patients, how are you feeling today? We try to understand how have they done over time. That helps us understand what their experience is, their responses. It's much more nuanced than this simple yes, no, they've gotten better or worse. And what they uncovered when they did this in the ISCHEMIA trial, which remember had an invasive and conservative arm for the treatment of angina, that after intervention, some patients had rapid relief. Others, more gradual improvement. Some experienced modest or no benefit, and a few had persistent severe symptoms, regardless of the strategy that they'd been allocated to. In fact, these classes, these 6 categories, were similar across the invasive and conservative arms. And that should resonate with clinicians because we see all sorts of different shades of response for patients after they undergo interventions. And so this is really just reflecting it. Now, the editorial says, quote, "The greater challenge is how we incorporate such information about symptom trajectories into our practice," end of quote. This analysis challenges the simplicity of just summary scores. It tells us how patients get better and when. It may matter as much as whether they get better at all. It strengthens the argument for longitudinal symptom monitoring in routine care. The results here may not influence our practice yet, but it's a step towards individualizing, a more precision approach, helping us to understand this and actually having the investigators appreciate what we're seeing in practice every day, which is that patients have different trajectories and that we need to begin to understand that and incorporate that into the studies themselves. The next study, statins for primary prevention in type 1 diabetes. We've known for decades that type 2 diabetes confers high cardiovascular risk and that statins reduce that risk. But what about type 1 diabetes? Believe it or not, no major trial has focused exclusively on this population. Actually, when this paper came in, I was thinking, haven't we had a trial on this? But the authors were right. There had not been a trial of this population. That's why this study from Bloss et al. Is so important. Using UK electronic health records and a target trial emulation framework, they modeled the effect of initiating statins in adults with type 1 diabetes and no known CVD. Now, we actually had a whole editorial on this target trial emulation. It's a way to take observational data and to position it to make a causal inference, to sort of emulate what a trial might find. Now, obviously, you lack the randomization. It's not the same as a trial, but it still provides stronger evidence than we've seen using other types of observational designs. Their findings: statins reduce the 10-year absolute risk of major cardiovascular events with stronger benefit in higher risk subgroups, especially women. There was no clear safety signal aside from small potential rise in liver enzyme biomarkers, which, by the way, gave me confidence that they might actually be measuring the right thing because that's what I would expect. This was a reassuring study that found really what we would have hoped to find, what we might have assumed to find. You may question, why did we publish it? Well, there was an absence of evidence in this area, and we felt that this really filled a gap. Kang et al. In the editorial praised the design. They talked about this target trial emulation being able to yield findings that can help us fill in gaps where trials are unlikely to be done or may take a long time to be done, and that, while not as strong as randomized trials, can, if done right, provide good evidence. And in this case, it affirmed the potential value of statins in type 1 diabetes and pointed to the benefit of earlier initiation in appropriate individuals. This is really a textbook application of modern causal inference to address longstanding clinical uncertainty. We also have a state-of-the-art review on moderate secondary mitral regurgitation. In this comprehensive review, Riccardi and colleagues address the increasingly murky territory of moderate secondary mitral regurgitation. Their key message is that the label moderate can obscure important clinical nuance. Severity varies dynamically with loading conditions, and exercise echocardiography and SMR can enhance the risk assessment for these patients. Optimizing GDMT remains foundational. Of course, that would be true in all patients. And some patients may improve without intervention. For others, particularly those with high regurgitant fraction or recurrent heart failure hospitalization, mTEER may be beneficial, but more evidence is needed. This review helps clinicians thread the needle between under and over treatment in this complex domain. We also had a trial perspective about asymmetric adherence in the PROTECT-TAVI trial. Kennedy et al. Present a methodologic analysis from the BHF PROTECT-TAVI trial, which evaluated cerebral embolic protection during TAVR. Here's the issue. Adherence to cerebral embolic protection was much lower in the treatment arm than in the control arm. And those excluded were older, more often women, and at higher stroke risk. This created asymmetric per-protocol groups, biasing results. Despite this, supplementary analyses that were done in this brief report affirmed the original ITT findings that CEP did not reduce stroke. The lesson is that real-world trial data sometimes need real-world analytic strategies to make up for issues that occur within the trials. ITT, intention to treat, remains the gold standard, even when adherence is imperfect. But these kind of supplementary analyses can be helpful as well. We feature a viewpoint from our group said, let's us call it cardiogenic pre-shock. Bloomer et al. From the Heart Failure Collaboratory propose a phenotype-based definition of pre-shock. They identified two subtypes, isolated low cardiac index and isolated hypotension. Their goal was to provide a granular risk classification within the broad SCAI-AB stages and encourage earlier target intervention for the proper people. What they're really saying is rather than waiting for full-blown shock, we need tools to recognize vulnerability earlier, both for clinical care and for research enrollment. And this issue, almost like always, has an Amara Yad image from Professor Shiv Kumar at UCLA. This one is the interior of the right ventricle. It's a visual reminder of the anatomic complexity and, honestly, the aesthetic wonder of the heart, equal parts science and art. And we also have some content from across the JACC family, a clinical anatomy guide for safe subclavian access, a case of regadenoson-induced STEMI, and a rare procedural rescue, TAVR, after failed valve-sparing root surgery. So what did we learn this week? Well, ECMO flow does not uniformly increase pulmonary capillary wedge pressure. In fact, higher flow can reduce LV filling pressures in some patients. 2, angina recovery is not binary. Patients follow distinct trajectories, and treatment should be matched accordingly. 3, statins are beneficial in type 1 diabetes. Target trial emulation closes a key evidence gap and supports earlier preventive therapy. 4, moderate mitral regurgitation is a moving target. New tools and timing strategies may help better identify who benefits from intervention. And finally, defining pre-shock may change practice. Granular risk definitions could enable earlier, more effective intervention. Well, that's it for this issue. I hope you've enjoyed it. And until next time, stay curious.